Heather DiCarlo, and I was fortunate enough to do my fellowship in pediatric urology at Johns Hopkins with Dr. Gerhardt and then stay on faculty. So extravy is a passion of mine, and it's truly been an honor to care for our patients at Hopkins. So I'll quickly go through a couple slides, and then I'll play a video for you about a really exciting project we've been working on. It really started with Dr. Gerhardt watching Dr. Carson operate years ago in neurosurgery and doing brain tumors. And that very delicate operation, you need to have some image guidance to get tumors out in these children. So Dr. Gerhardt would watch Dr. Carson take these very, very large tumors out of patients and preserve every part of their brain, spinal cord, using this system called its Brain Lab. It's an intraoperative imaging and image guidance of the surgery. So Dr. Gerhardt thought, wouldn't this be wonderful to help us teach both our residents and other urologists throughout the world how to do a proper dissection when they're taking care of patients with bladder exstrophy? And with a lot of work that went into it before my time at Hopkins, getting FDA approval, we were able to get this program going, and it's been really wonderful and exciting and helps us not only teach our residents and our medical students, but other people throughout the world. So I'll tell you a little bit about that. This work has been supported by one of our donors, by the Kwok Family Foundation. So just overall, with our evaluation of patients with bladder exstrophy, the first thing we do is we evaluate them when they're born, look at the size of the bladder template, whether or not they're going to be closable using an examiner anesthesia, see that there's the presence of polyps and other anomalies going along. Little things that we do, we will make sure that we tie off the umbilical stump so there's not any kind of scratching of the bladder template while we're waiting to close these patients. So examination under anesthesia, we see how malleable the bladder is and how malleable the pelvis is, as Dr. Gerhardt described with Dr. Sponseller, our pediatric orthopedic surgeon who basically invented the osteotomies that are done in these patients. So these are some pictures you can see here of evaluations under anesthesia. Part of that as well with our preoperative evaluation is also imaging to see the size of the diastasis, the space between the pelvic bones, as well as seeing if there's any sort of anomalies going on with the kidneys so we can do the best operation when we're taking care of these patients. Something we've done is we've been getting these preoperative MRIs that have helped us not only with primary closures, so patients that are brand new, babies that are born prior to closure, but also patients that are referred to Dr. Gerhardt with failed closures that need reclosure, because the anatomy isn't always very straightforward. So you see here some ultrasounds we have. There was a child that was born with classic bladder exstrophy. She had a duplication anomaly of one kidney. In other words, there were two ureters draining her kidney. Her kidney was split into two, and the upper pole of the kidney was blocked. So at that time, we were able to reimplant the ureter into the bladder to treat her obstruction and also allow her kidney to develop more fully. So this is something that goes along with our MRI. So basically, and I'm going to go through these slides quickly because they're in the video, we really want to get a good dissection of the pelvic floor to allow the bladder to be dropped in its proper anatomic location so you can have a successful closure. And this is how Dr. Gerhardt was thinking about using the MRI, which is obtained the day before surgery, and using the Brain Lab system. It integrates the anatomy real time to the MRI so you can see the pelvic floor anatomy, and it helps us with our dissection. So basically that we obtained FDA approval, and it was the fellow of the year ahead of me, Dr. Masani, who's in Akron, Ohio now, and Dr. Shaw, who's down in Tampa, Florida. They did all the legwork to get this going. So it's been really a wonderful, wonderful process. So we get in patients that are going to be closed with classic bladder exstrophy and cloacal exstrophy, we get an MRI the day before, and then we plan with one of our radiologists, an outstanding neuro and uro radiologist, Dr. Tekish. We do the planning that allows us to integrate the anatomy on the patient with the actual imaging anatomy. Here's some pictures here. You can actually see this is during closure. There's an array right there, those three balls that are connected to the metal device. That actually is a sensor for the infrared to be able to be read by the machine. And when we point to different anatomic landmarks on the patient, you're able to actually see exactly where you're working in the body. And this is even after the osteotomies where there is some movement in the pelvis. This is us working with me during my fellowship with one of our chief residents using the system here, and you can actually see where I'm pointing with the stylet is correlating to our workstation here. This is a 3D reconstruction of a patient with bladder exstrophy. You can see there too, the green is the stylet as I'm pointing to the various anatomic landmarks. And the colors you see are actually the drawings of the pelvic floor anatomy musculature that I worked with Dr. Tekish the day before surgery to plan. So we've done overall 34 patients, 2 with cloacal extravasation and 32 with classic bladder extravasation. Basically half and half have been primary versus secondary closures. In our classic bladder extravasation, all the cloacals have been primary closures. And things have gone well with these patients. I mean, we're lucky to have the hands of Dr. Gerhardt when I work alongside him to be able to check things, but these patients have been doing fantastic. So we've had 100% accuracy in this. So with the actual movement of the pelvic floor and also the osteotomies, we're seeing that everything's correlating anatomically. And not only myself and Dr. Gerhardt, but our radiologists and our fellows confirm this as well, that the anatomy is accurate. The great things about this is that it's not only for patient safety, for reclosures, allowing good, safe dissection, allowing for teaching of our residents. We're also looking into the role for secondary closures and cloacal extravasation, and we're going to be selecting. We have 3 upcoming this summer that we're going to be working on, which is very exciting, so we'll keep you all posted on that. We have 2 telementoring opportunities, both in Manchester as well as in Saudi Arabia, where myself, I can go out that way, and Dr. Gerhardt can be home in Baltimore and can guide us through the dissection. So it's very, very, very positive being able to bring the techniques to patients and physicians around the world. So I'm going to play the video for you next. Radical dissection of the urogenital diaphragm fibers and the thickened, smooth, and striated muscle fibers connecting the posterior urethra and bladder plate to the diastatic pubic rami is crucial for adequate bladder extravasation and cloacal extravasation closure, as well as ensuring successful outcomes. Intraoperative MRI-guided navigation of the pelvic floor offers a novel technique for identification of the urogenital diaphragm fibers and the thickened muscular attachments between the posterior urethra, bladder plate, and pubic rami during closure, allowing identification of crucial anatomic landmarks and precise dissection in this crucial step of reconstructive surgery. IRB and FDA approval was obtained for use of BrainLab intraoperative MRI-guided navigation of the pelvic floor anatomy during closure of classic bladder extravasation and cloacal extravasation at our institution. Preoperative pelvic MRI was obtained 1 day prior to classic bladder extravasation or cloacal extravasation closure in patients necessitating pelvic osteotomies. The pediatric urologist and the pediatric radiologist sit and do intraoperative pelvic MRI planning prior to the procedure. Using iPlanNet BrainLab computational system, bony pelvic anatomic landmarks and the pelvic muscular anatomy are drawn on the MRI. Puborectalis. Here we see 3D reconstruction of the pelvic floor anatomy in a bladder extravasation patient. Intraoperative registration is performed after preoperative planning with a pediatric radiologist and pediatric urologist, utilizing bony anatomic landmarks. A reference array is attached to the patient via a head strap, and the bony anatomic landmarks are pointed out using a stylet. This correlates to the MRI, which is loaded on the BrainLab system. This step is performed prior to the pediatric orthopedic surgeon performing pelvic osteotomies. The patient's then prepped and draped, and osteotomies are performed. Anatomic accuracy is correlated, and the soft tissue dissection is performed with guidance of the pelvic floor anatomy utilizing the MRI. The position of the tip of the stylet correlates with the MRI images on the screen of the BrainLab computer. We see here the pelvic floor muscular anatomy outlined in color. There are axial, sagittal, and coronal images, as well as 3D reconstructive images. BrainLab intraoperative MRI-guided pelvic floor navigation and dissection is an effective way to accurately identify pelvic anatomy during classic bladder exstrophy and cloacal exstrophy closure. This technology offers a unique opportunity for surgical skill education in this complex reconstructive operation. It also allows for increased safety with the accurate identification of critical pelvic floor anatomy, as well as the potential for improved surgical outcomes. Future assessment of real-time changes in pelvic floor anatomy, comparing pre-closure to post-closure MRI, will allow for quantification of pelvic floor anatomy in classic bladder exstrophy and cloacal exstrophy patients. BrainLab technology also allows for intra-institutional telementoring in this most important first step of exstrophy reconstruction.